Hello, my name is Dr. Bonnie Key, and I'm the Editor-in-Chief of JACC Cardio-Oncology and the Founders Associate Professor of Cardio-Oncology at the Perelman School of Medicine at the University of Pennsylvania. Today, I am joined by Drs. Leah Zullig, Kevin Oeffinger, and Susan Dent, who serve as the first and corresponding and senior authors on a state-of-the-art review that we are very pleased to publish in our June 2022 issue of JACC Cardio-Oncology. It's entitled Cardiometabolic Comorbidities in Cancer Survivors. Leah, Susan, and Kevin, thank you so much for joining me today and for this truly important contribution by you and your co-authors to our journal. We are very, very happy to publish it.
Thank you.
Thanks. So I wanted to share some pieces, some key highlights of your very important piece for our community. And so I wanted to have a conversation with each of you about this. So let's start with Kevin. Kevin, in your view, what are the three most important take-home messages for our readers from your important state-of-the-art review?
Thanks so much, Bonnie. I think the first one is that the old conventional approach to one clinician or one physician handling everything is not good medicine anymore. Care of cancer patients is quite complex, and our oncologists really need to be focused in on the care and delivering that curative or cancer control therapy. While the primary care clinician and the cardiologists are really quite important in that one team approach of helping out, making sure that we're managing cardiometabolic comorbidities such as hypertension, diabetes, or lipid disorders. Many of us realize now that with the improvements of cancer therapy, patients are more likely to die of a cardiovascular event than they are from their original cancer. So it's really important for us to focus in on those cardiometabolic conditions and really pay attention to adherence, understanding that patients are dealing with a lot of medications, medication changes, and things of that nature. So we need to work as one team to emphasize adherence, managing those comorbidities, and moving away from the old way of one person taking care of everything.
Those are really excellent points. And one of the things I really loved about your state-of-the-art review too was that focus on adherence and practical strategies, as well as the focus on these modifiable cardiovascular risk factors that are so important to manage and pay attention to. Susan, in your view, what do you think are the most practical evidence-based strategies to manage hypertension, a key modifiable risk factor in our cancer patients and survivors?
Thank you, Bonnie. I think, Bonnie, the first thing that we need to recognize is that hypertension in cancer survivors is common. And so when you think about it, 1 in 3 Americans will have hypertension diagnosis between the ages of 40 and 59, and 2/3 of the US population are diagnosed with cancer over the age of 65. So we can expect to see hypertension in many of our cancer survivors. And then, we take them and we give them cancer therapies, which have led to improvements in cancer outcomes. But also these cancer therapies, such as VEGF inhibitors, an example being bevacizumab, or tyrosine kinase inhibitors, such as ibrutinib and CLL, can exacerbate pre-existing hypertension, or these patients can develop new onset hypertension. And then they complete their cancer therapy, if they're fortunate enough. These patients remain at risk because they may have been deconditioned from their cancer treatment, they may have gained weight, lifestyle changes, lack of exercise, or, for increasing number of our patient population, they continue on chronic therapy because they're living with cancer. They're not cured, but they're living with chronic disease. So it's really a spectrum of people that we treat. So when we think about how do we manage hypertension, the one thing we have to realize is there are currently no evidence-based guidelines specifically for cancer patients. So we rely on the non-cancer population guidelines that have been published by a number of organizations like the American Heart Association and the American College of Cardiology, with the caveat that we would expect patients to have the same benefit, even though they have cancer, compared to the non-cancer population. So for those patients presenting with pre-existing hypertension, I think we can follow the current guidelines, and they outline ACE inhibitors and ARBs to try and control hypertension, ideally before you start your treatment. And then for patients who are on active cancer therapy, It's a similar drugs, but I think there's a few caveats that we have to realize that, there are classes of antihypertensives out there, such as the thiazide diuretics, which may not be my number one choice because these patients have symptoms such as nausea, vomiting, they get fluid depleted and electrolyte imbalances. So that may be an issue. So I would perhaps avoid those type of agents. And then the other one is calcium channel blockers, because calcium channel blockers like diltiazem, for example, are metabolized to the CYP3A4 system, and they interact with a lot of cancer drugs. So that's also one to be careful about. And then into, beyond cancer therapy, we can also think of stratifying how we approach hypertension management based on whether patients have been exposed to cardiotoxic drugs. So for instance, if they have been, our target maybe less than 130/80 for their blood pressure management. And if they're not at risk, 140/90. And there's been a lot of talk about what's the optimal target. And then if underlying and underpinning all of this, I just want to stress that, as oncologists, we are great at taking care of the cancer care part of our patients, but we need to look beyond ourselves and interact with our colleagues and primary care providers to actually manage the hypertension. So it's not just a question of how do we manage it, but it's who is going to manage that hypertension with us in cancer survivors.
Excellent point, Susan. Absolutely. Multidisciplinary collaboration amongst the care team provider with the patient at the centers is clearly key to the future of cardio-oncology and the future of medicine. And along these lines, all of us, as we work together to help our patients and advocate for them, I think a key thing that we've also recognized as providers is adherence. It's hard to take medicines every day. And again, one of the great features of your state-of-the-art view was you discussed the phases of adherence and strategies to help implement them. Leah, can you tell us a little bit more about this?
Yes, thank you. That's a very insightful question, I think. So there are 3 phases of medication adherence. The first phase that we think about is initiation. So starting to take a new medication for the first time. And then the second phase is implementation. So this is how a patient's actual dosing aligns with what was prescribed by their provider. And then third, we think about persistence. So this is the time that a patient actually starts taking the medication longitudinally until they discontinue for any reason, whether that's consistent with a provider's direction or something that they determine to do independently on their own. And we know that patients have different behaviors that are needed at each of these different phases. So successful adherence support at each of these phases is going to target and tackle each of these sets of behaviors. So for example, at the initiation phase, patients may need help changing their perceived beliefs about a medication or their perceived need for a medication. They may also need help navigating payment issues, things like prior authorization and so on. And then throughout the implementation phase, patients may need help with reminders, perhaps medication synchronization for patients that are on polypharmacy, and troubleshooting any changes as their cancer progresses, how they might need to adjust and think about prescribing differently.
Great points, and great points about how much behavior actually affects all of these patterns of adherence, and really interesting science out there. In closing, Kevin, tell us a little bit about the paradigm and what you promoted about the medical home for the cancer survivor. Tell our community about this and what your thoughts here are.
Thanks so much, Bonnie. The whole concept of medical home really was born several decades ago by the American Academy of Pediatrics of how to take care of children with special care needs or chronic diseases. And it recognized that it's more than just the patient, the family, and the caregiver, and a single provider, but a whole team of providers. The old adage is it takes a village. Yeah. We've seen that through cancer care. In fact, that's the whole spirit of cardio-oncology. It is not just the cardiologist or the oncologist or the primary care clinician or the population scientist, et cetera. It's everybody that's working together with the patient, the family, and the caregiver in the middle. So we have a figure that actually depicts that, pardon me, and thinks of the allocation of responsibilities. And one of the things we don't do well in medicine is deciding who's on first and what's on second. You're responsible for this, I'm responsible for that, and making it clear. One of the things that we really advocate in the paper is that primary care clinician, the cardiologist have very specific responsibilities. The oncologist has very specific responsibilities, and communicating and reporting back to one another is essential for good care and for good outcomes for our patients.
Excellent, excellent take-home points. Patient and their family at the center. And we need to focus on communication. That's really critical. And that is our hope for cardio-oncology. Well, Leah, Susan, Kevin, thank you so much for joining me today. And again, thank you so much for your very excellent piece.
Thank you, Bonnie.
Thank you.
Thank you.